Welcome back, students, to The Explainer. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'm absolutely thrilled to have you all back in the classroom today. We are continuing our 150-part IPDRG masterclass, and let me tell you, today is an absolute powerhouse of a lesson. We're diving deep into Part 82, Advanced Surgical DRG Deep Dive, focusing specifically on major diagnostic categories 05, invasive and interventional cardiology. Let's get right into it.
Here's a quick look at our syllabus for today. We've got our intro and recap, MDC 05 surgical logic, the high-volume DRGs, precision and audit defense, and then our summary and Part 83 teaser. Okay, let's keep moving.
Section 1, Part 81 recap, and the MDC 05 shift.
To ground ourselves for a second, in Part 81, we comprehensively covered the medical side of MDC 05, right? We mapped out conditions like heart failure and acute myocardial infarctions. But today the stakes are elevated. We are shifting away from just medical management to the high-stakes surgical side of the cardiovascular system. Now, within the MS-DRG architecture, cases are partitioned into medical or surgical groups. The absolute golden rule here, and you cannot forget this, is that if a procedure is present that meets the CMS definition of a major operating room procedure, it actively overrides the medical diagnosis. Think about it. A patient admitted for heart failure who then receives a major valve replacement is instantly shifted from a medical DRG to a much higher-weighted surgical DRG. It changes the entire grouping.
Okay, let's dive in to how this landscape has evolved. The whole surgical hierarchy used to be completely dominated by traditional, highly invasive open sternotomy procedures, cracking the chest. But as clinical science has advanced, so has our coding logic. It's like a giant puzzle that keeps shifting. We are now seeing a massive shift towards minimally invasive, endovascular, and percutaneous interventions. As a coder, recognizing whether a surgical approach is open or percutaneous is absolutely vital. CMS is regularly introducing new MS-DRGs, like the recent endovascular abdominal aorta procedures, just to accommodate these modern techniques. You've got to stay on your toes.
Section 2. High-volume surgical and interventional cardiovascular DRG families.
All right, now that we understand the basic hierarchy, let's look at the heavy hitters you're going to encounter every single day. First up is the coronary artery bypass graft, or CABG, represented in MS-DRGs 231 through 236. The partitioning here is incredibly specific, and honestly, it relies heavily on co-procedures. Check this out. If a CABG is performed alongside a PTCA, a percutaneous transluminal coronary angioplasty, it groups to 231 or 232. But if it's performed with a cardiac catheterization, it maps to 233 or 234. And without a cath, you're looking at 235 or 236. Your procedure coding literally has to capture all these moving parts or the whole thing falls apart.
So to properly assign those DRGs, the ICD-10 PCS bypass coding logic requires absolute laser-like precision. You can't just slap a cabbage code on it and call it a day. No way. You really need to comb through that operative report to qualify if the surgeon used an internal mammary artery, an IMA, or a saphenous vein graft, an SVG. You also have to identify the exact origin and destination points, like was it from the aorta to the coronary artery? And hey, don't forget the qualifiers. If a saphenous vein graft is harvested, you often need an entirely separate additional code just for the excision of that vein. It's all about the details.
Now, let's shift gears and talk about heart valves. There is a very strict coding distinction between open heart valve surgeries and endovascular procedures. Open surgical replacements of the aortic, mitral, or tricuspid valves group into MS-DRGs 216 through 221. However, modern endovascular techniques like TAVR or TAVI, transcatheter aortic valve replacements, they have their own dedicated families in MS-DRGs 266 and 267. Misidentifying the surgical approach here, that will completely derail your DRG assignment. You've got to get that right.
And it doesn't stop there. Beyond standard valve replacements, you've also got to be on the lookout for other major structural heart procedures. We're talking about things like transcatheter edge-to-edge repair, which you'll often see referred to as TER or the MitraClip procedure. Then there are left atrial appendage closures like the Watchman device, as well as closures for atrial and ventricular septal defects. Each of these percutaneous structural interventions has a profound impact on that cardiovascular surgical hierarchy we talked about earlier.
And this brilliantly illustrates the mechanics of percutaneous cardiovascular interventions, or PCI. Here we can clearly see how various atherectomy devices, directional, rotational, transluminal extraction, and laser, are used to actively remove plaque from a blocked artery.
The whole goal here is to widen that artery so blood can flow more freely to the heart muscle. In ICD-10 PCS, capturing the exact intraluminal device used here isn't just a suggestion, it is absolutely mandatory.
Now, take a close look at the critical classification difference between these stents. When a stent is placed during a PCI, you must aggressively scour the documentation to figure out if it is a drug-eluting stent, a DES, or a non-drug-eluting stent, an NDES. This single, tiny qualifier alters the DRG entirely. A DES might land your case in MS-DRG 246 or 247, whereas an NDES drops the case all the way down into MS-DRG 249. Missing this detail means you are completely misrepresenting the clinical complexity and the actual resources the hospital utilized.
Furthermore, for PCI procedures, the stakes are incredibly high when it comes to counting. Seriously, the ICD-10 PCS tables explicitly require you to track the exact number of treated vessels. There is a massive difference in DRG grouping if you treat 1 to 3 vessels versus 4 or more drug-eluting stents. Couple this with ensuring that any acute myocardial infarction is properly linked as the principal or secondary diagnosis, and you are directly dictating the accuracy of the hospital's reimbursement. It really is a game of precision.
Okay, for our final procedural category, let's walk through the logical steps for coding cardiac pacemakers and AICDs, automated implantable cardioverter defibrillators. Coding these devices is practically a multi-step dance. Step 1. You code the insertion of the device generator itself, making sure to specify if it's a single, dual, or biventricular device. Step 2. You code the placement of the cardiac leads, mapping them to the specific heart chamber, like the right atrium or left ventricle. And finally, Step 3, you have to capture any necessary repositioning or extraction of old components. You need the whole shebang.
Section 3. ICD-10 PCS, Precision and Audit Defense.
So, as we've seen, getting the procedure code right is really only half the battle. Let's see how all this builds our 7-character ICD-10 PCS code, using a standard CABG as our example. Character 1 is the section, 0 for medical and surgical. Character 2 is body system, 2 for heart in great vessels. Moving on to character 3, the root operation, 1 for bypass. Character 4 is the body part, 0 for a single coronary artery site. Character 5, approach, 3 for open. Character 6, device, 1 for an autologous artery graft, and finally, character 7, the qualifier, Z for no qualifier. Literally, every single character here must be precisely supported by the operative report. You cannot guess on any of them. Now, in the post-operative phase for cardiac patients, capturing high-yield secondary diagnoses is absolutely vital for adjusting the DRG severity. Conditions like post-cardiactomy cardiogenic shock, acute kidney injury, or cardiac tamponade, these are all major complications and comorbidities, or MCCs. Another massive impact on grouping is capturing respiratory failure that requires prolonged mechanical ventilation exceeding 96 consecutive hours. These secondary diagnoses aren't just extra fluff, they prove the extreme severity of illness that these patients are actually facing.
But here's where you're going to face auditor challenges. Picture this. You have a patient with anemia following a major open heart surgery. A very common compliance target for payers is questioning the validity of these post-operative sequelae. So, what does this all mean for you? You must ask the clinical documentation a tough question. Is this post-op anemia just an expected transient drop in hemoglobin due to the massive surgery, or is it an active, unexpected complication?
So, the crucial point here is understanding the true definition of a clinical complication. To successfully survive a payer denial defense, and trust me, they will deny it if they can, the documentation must clearly show that the condition, like that post-op anemia, required active therapeutic treatment, diagnostic procedures, increasing nursing care, or extended the hospital stay. If it doesn't meet those specific criteria, it's just an expected outcome and should absolutely not be coded as a severity-altering complication.
Section 4. Summary and Part 83 Teaser. Wow, okay, we have covered a massive amount of highly technical ground today. Let's lock in your learning with the 3 main takeaways for MDC-05. Number 1. Remember that surgical OR procedures will always override a medical principal diagnosis, completely shifting the MS-DRG. Number 2. Procedures like PCIs and CABGs demand the absolute highest level of ICD-10 PCS specificity. Count those vessels, verify those stent types, and track the bypass routes. And number 3, always defend your codes by ensuring complications are backed by documented, active clinical intervention.
That officially wraps up our deep dive into the cardiovascular surgical hierarchy. But I want to leave you with a question to ponder. Is your facility leaving crucial reimbursement on the table right now because of a missed stent qualifier or an undefended complication? Precision is your best defense. Coming up next in our syllabus is Part 83, where we shift gears entirely and dive into the respiratory system. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you all in the next module.